I guess, as we suggested, one of the biggest obstacles, I think, is communicating this to the patient. And in my opinion, this is something that should start pretty early in the illness, that once you're having that psychoeducation discussion with a patient about the nature of the illness, the fact that medication is very important in managing the illness and preventing relapse. Once we accept the fact that medication is important, then why not turn to an alternative that provides guaranteed medication so we can be confident that the person is actually getting the benefit of the treatments that we've developed. And I think patients, if it's explained in the right way, I think patients can be very receptive to that concept. And I think the sooner we introduce it, the more it becomes an expectation of the treatment plan. When somebody leaves the hospital and 6 months later or 12 months later, someone suggests, well, maybe we should try a long-acting drug, I think that might be less likely to succeed than if it's presented to the patient as, well, this is the way we treat your illness. First, we're going to start with oral medicine. We're going to see how you tolerate it. We're going to make sure you respond. Then we're going to switch to a long-acting formulation, and that's what you'll be on when you're out of the hospital. I think that would have a chance of working much better.
Now, this in first episode psychosis, this is the one place where there's a pretty good randomized controlled trial showing some advantages of shots over pills,
yes,
right?
And there was this.
The UCLA study?
Yeah, the UCLA study. That it was a pretty dramatic reduction, which is a real outlier compared to the other studies. I'm not quite sure why that is, but it's a legitimate RCT.
Yes, and there are attempts to replicate that, and I think they're also, interestingly, in that study, they also found an increase in cortical myelination amongst the patients receiving the long-acting formulation of risperidone as compared to the patients receiving the oral formulation of risperidone, which is a very interesting finding that needs to be replicated.
I do think there's something about, though, being able to adjust the doses sort of quickly in these people who are being exposed to antipsychotics for the first time, just to avoid, bad experiences.
Right, so you wouldn't necessarily want to start someone on a long-acting formulation. You'd want to start with oral, get the dose right, make sure it's the minimum effective dose, but then potentially transition to a long-acting formulation.
Pretty quickly.
Yeah. But that leads into another question about the dose adjustments. So, you were just saying it's easier to adjust dose with an oral medicine, but do you think that will interfere with our ability to optimally use the long-acting formulations? Because we can supplement with oral if we have to, right?
That's true. And, I think it's initially, when you're trying to find the right dose and avoid too many side effects, I'm not a big believer in micro-adjusting as you go on. So I think once you find a dose that works, I think there's less of an issue with the problems with long-acting injectables in that way. But I don't typically adjust the dose every visit if there's a slight issue.
Right. And Jeffrey, what do you think? Are there any disadvantages to long-acting injectable formulations?
Nope. I think that the fact that we don't use them as much as, or more than we do, analogous to the underutilization of clozapine, is really, there's no excuse for it. It's an embarrassment, to our field that we don't. There may be deterrence, we don't have a nurse, we don't have the infrastructure, we don't have this. It's the blood draws and WBC levels are a pain. Those are excuses. It's just, there's no disadvantage to long-acting. In fact, there's potentially considerable advantages. I mean, the main one, of course, is adherence, that it facilitates adherence. But even beyond that, it may be a more effective mode of delivery of antipsychotic medicine because you don't have the peaks and troughs, you don't have as much of the pharmacokinetic variation with the blood levels of the drug. The substance in which it's esterified with or is formulated with acts as a absorptive, it facilitates penetration into the blood-brain barrier as well. And so there's no downside it's just the pragmatics of, as you say, educating people to overcome the aversion to injections and whatever the hassle is. And it would be great to build it into a process of orienting patients to what the logical sequence of their treatment would be, including the conversion to LAIs. But it's not done. How many guidelines have you seen where that's part of the recommended process?
I think the guidelines actually have been a little weak, in all honesty, because if you look at the APA guidelines, they kind of suggest that you want to see multiple relapses before you consider an LAI, which I think is really misguided. It's like, why would you want to see multiple relapses? You know, I think we want to try to prevent as many relapses as possible. But there are still many clinicians out there who say, well, I will assume that the patient is adherent until they show me that they're not. And you know, the only way that we learn that someone's non-adherent is when they get sick again. So it's an unfortunate way to learn. And I think there's still a little bit of a disconnect there.
Maybe we should use contingency reinforcement to physicians to use prescribe
well,
LAIs.
that's no joke. I mean, because if we agree, and as Scott suggested, that both clozapine and LAIs involve perhaps a little more effort and a little more hassle, some clinicians would say, well, I'm not incentivized to spend more time doing this.
Yeah, that's a good point, John, because the other thing, and I mean, we shouldn't be so tough on our colleagues, is that and look at the infrastructure by which mental health care is provided in many places. You know, you've got a doctor with a lot of, paraprofessionals, and the doctor's got like 10 minutes to see a patient and go through the whole process of evaluation and then prescription. So, it doesn't, sort of facilitate the optimal level of care, including, how to be able to introduce other modalities like LAIs.
So, go ahead.
No, I was saying, again, you're reminding me of the analogy to clozapine. Going serially through lots of oral medications, there's no real benefit from doing that. I mean, changing meds helps you get away from side effects, but doesn't really get you to better efficacy or adherence. So I think pretty quickly you should be considering long-acting injectables or clozapine. And I think you can debate which one of those should come first.
John, which country do you think comes closest to using them in an optimal way?
The last data I saw, I know Spain had an increase in utilization rates, but I haven't seen any recent data. I think most countries around the world are still using them less than they should be. Same with clozapine. I mean, it's interesting. As you said, there are really strong analogies between these two. And maybe it's training also. I mean, I think there are, if you talk to some of the residents who've trained in places where LAIs are not widely used, they're not as comfortable. If you talk to residents who've trained in places where they don't use a lot of clozapine, I think we have to make sure that it's part of the training.
Yep.